Hello everyone, and welcome to our health reform update for 2014. As you can see from the title slide, Preparing for 2014 Part 1, this suggests that there's going to be a Part 2. Part 2 is not today. Part 2 will probably be late summer. In October of 2014, there will be major changes in both the state and the federal regulations. That's when we intend to do Part 2. As with all of our previous health reform updates, these programs are dated. We are constantly experiencing changes at both the federal and the state level, and therefore it's important to recognize that this material was effective by about March 1st, 2014, and probably continued to be changed after that. So if you're listening to this program at a later date, you may want to get in touch with a Ward and Brown representative in order to make sure that everything you're seeing in this program is still effective. Part 1 of 2014 actually picks up a few months ago in 2013. When last we were doing these programs, we had not yet had the material that got developed in September of 2013, so we want to pick up our pace there. Before we get going, though, I want to talk about something called a safe harbor. Basically, a safe harbor is when a rule has been propagated by the federal government or the state government, which is incomplete. The details of the regulations are not quite clear. They need some practical experience in the field before they can define exactly what's happening. So they basically say, in this case, to the employer, you have to make a best faith effort with the regulations we're articulating at this point in time. If you make your best faith effort, you have a safe harbor against being charged with certain mistakes that could occur. We're going to talk about some of those kinds of errors that may occur. It basically is a way to sort of test drive a series of regulations before anyone gets penalized on them. So as you listen to us today, I'm going to talk about a number of safe harbors, but I want to make sure that you understand you're still obligated to do your best faith effort regardless of the complex regulations. You're going to also find that in many cases our carriers have differences of opinion. These complex regulations can be interpreted a number of different ways, and different carriers are going to have different guidance, slightly different guidance. So when we talk about things today, keep in mind that one carrier may interpret something one way, another carrier another way, and each of them could be relying upon their best faith effort and the safe harbor that falls within that. When we talk about the first thing we're going to be analyzing today, I want to make sure you keep in mind this safe harbor for the carriers. If in doubt, hand it out and follow whatever your carrier is saying. So while I'm going to be doing a general review on some regulations, if, for example, you have plans with Blue Cross and Blue Cross is telling you that for Blue Cross plans you do it this way or that way, and you have other plans that are with Blue Shield and they're telling you to do it some other way, in each case, I would follow the carrier's guidance because from an employer's point of view, the best safe harbor, the best faith effort is simply to do that which the carrier told them to do. That's particularly going to be the case when we talk about these Summary of Benefits and Coverage, or SBCs. SBCs are a standardized report that is supposed to be handed out to employees under certain conditions. The report has to be a standardized report, as you can see by the slide. It has certain printing minimum formats, such as it must be 4 pages of double-sided 12-point font. Can't be 11-point, can't be 13-point, can't be 6 pages, 5 pages, 3 pages. It has to be exactly 4 pages. These formats you're seeing on the screen can be found at the irs.gov website. The formats are very, very specific, and they must be linguistically appropriate. Each of our carriers is deciding what is linguistically appropriate for their clientele. If you're a person who uses a summary plan description, SPD, you're certainly allowed, and we of course recommend that you continue to do the SPDs, but the SPC is in addition to it. The SPD does different things than the SPC, as you're going to see. So if you're accustomed to using SPDs, continue handing those out along with the SPC. Now the IRS is very specific. As I said, irs.gov, if you go there, you'll find the templates. The templates are very specific and you need to follow them. One of the things that has changed since the original announcement regulations was that originally premiums were going to have to be included in these printouts that are handed to the employees. That is no longer the case. You have a safe harbor not to supply premiums to the employees. There's also a uniform glossary of terms. Again, go to the irs.gov website to find those terms. As you can see, the SBC, first and foremost, is a summary of medical scenarios. It basically does two things. It asks some overall questions, such as what is an overall deductible, and then you have to supply some answers. It is also going to ask some very specific medical questions, such as what happens if I have a baby, or how is the claim processed for diabetes type 2. As you can see, you can imagine, for example, a self-funded plan with perhaps an employer who wants to have multiple kinds of deductions in order to encourage people to approach their policy a particular way, maybe a different deductible for an emergency room versus an urgent care. It's conceivable that in the category of second, are there other deductibles for specific services, it's conceivable that there are so many deductibles you cannot possibly fit them all into that little box. Let's say you have 12 different deductibles. Well, we've already talked about you're only allowed to use 4 two-sided pages, and you don't use a 12-point font. Well, you couldn't possibly get 12 different deductibles in that little box. Any word processing program or desktop publishing program is simply going to stretch the box, making page 12 become page 13 and 14, etc. Well, your best faith effort is to accurately describe the policy. Therefore, you would have a safe harbor of moving to the 13th, 14th, or 15th pages, as opposed to attempting to reduce it down to 8-point unreadable type. So your best effort would be to change the number of pages, and some carriers may do that. As you can see from this next slide, here are specific examples of how's my claim going to be paid if I have a baby or if I'm managing type 2 diabetes for the plan that's being sold in that particular company. You don't get a choice as to which medical scenarios you get to play by. You may have a bunch of all young males, none of them married, but they still need to know how their claim is going to be paid if they have a baby. That's going to be a trick, of course, and you do want to call Guinness Book of World Records, but other than that, somebody might say, my young man might prefer to know what's going to happen if I have a skiing accident or a hunting accident or something like that, but that's not in the medical scenarios by the IRS. You have to do exactly the ones the IRS requires. Everyone is required to do these things. This is not a small group or a large group situation. All fully insured, partially informed, insured, or self-insured plans. Large, small, or individual. Now, rather obviously, the individual plans are done by the carrier. Grandfathering does not matter. Grandfather plans have to do it. You don't have to have these for standalone, such as dental, vision, etc. But if you have a plan in which dental or vision is intrinsically wrapped into the health insurance plan, then the dental and vision benefits must also be part of the SBC. Fully insured carriers are obligated to provide the SBC, but the employer is liable for its distribution. In a self-funding arrangement, the employer is the one that is responsible for both the production of the SBC as well as the distribution. In that particular case, you'd be well advised, if you're operating with a self-fund plan, to contract the production of the SBC out to a third party, such as the administrator or someone who can do that work. I wouldn't advise having a HR department trying to design its own summary benefits in order to fill the requirement. Self-funded plans can be pretty intrinsic at some point, so an expert producing the document is the way to go. However, if you're dealing with a fully insured carrier, they will be supplying the documents to the employer, and the employer is responsible for its distribution. You need to be checking your calendars on this one, because here's where carriers differ a little bit. The rules went into effect at the end of our last set of health reform programs early last fall. Starting on September 23rd, 2012, at the annual renewal or any first effective date for non-annual events, you were supposed to be handing these things out. As most of us know, we did not hand them out for October 1st renewals or October 1st new sales because they weren't available from the carrier. Most of the carriers are out there doing it now, but where there's differences of agreement is, am I obligated to hand out the SBC anytime after September 23rd where it applies, or only after my group has renewed, and different carriers are giving different sets of advice. If in doubt, hand it out is our suggestion and follow what your carrier is saying. So for example, even if I did not come up for renewal until June 1st, 2014, I might still hand out the SBC for new hire. Whether you agree that the action should be after the next renewal, past September 23rd, 2012, or for all events after September 23rd, 2012, keep in mind that individual acts as well as the group acts can result in needing to hand out the SBC. For example, let's assume you have two carriers in the same group that are renewing at different times. Let's say one of the carriers dropped a plan, automatically assigned everybody to a new plan. I would suggest an SBC goes out to everyone at that point. Any special enrollment situations, a man gets married, adds a spouse, a family has a new baby. I'm covered by my spouse's plan, therefore I was a non-enrollee the last time we enrolled, but now my wife has lost her job and I'm liable to come back in as a late enrollee. You would hand out the SBCs in those situations. So any special open enrollment situation, and there's a special clause that any employee asking for the SBCs has to be given the SBC within 7 business days. If you have any kind of material modification, maybe in 2014, Part 1. Well, our exchange here in the state of California is making rapid progress. It's called the California Health Benefit Exchange. That's kind of its generic name, but we're going to find out it has a new marketing name, and that's going to be important because the new California Exchange will be up and enrolling people by October 1st, 2013. It'll be operating in the virtual world of computers by about midsummer. What can we expect? Well, for starters, it's already been announced that brokers are going to be part of the Navigator program. Brokers will be allowed to sell through the exchange. There's going to be issues about licensure that have not yet been resolved. Clearly, nonprofit organizations may be assisting the lowest income levels, citizens who may not be buying a policy but may be getting the policies with enormous support or perhaps even for free. So those nonprofits are going to have to get involved in some kind of licensure, just as a broker is going to have to be involved in some kind of licensure for this exchange. The way to think about this licensure is pretty simple. If a new carrier came to town and said, if you want to sell our product, you're going to have to attend some training classes, you'd be happy to attend the training classes in order to sell the new carrier. Think of the exchange in those manners. You have to go through licensures and you have to go through training. Right as of this point, we don't know the number of hours nor what kind of licensures everybody will have. The rumor as of this statement is that nonprofits wanting to participate in the exchange will get some kind of license which you hold, a broker or selling license, while you will have to go through training issues to deal with the nonprofit side as well as the profit side. And that may be 6, 8, 12, 16 hours. It's hard to know. Decisions have not yet been made in terms of whether it be by web or by live classroom settings. The commission issue is pretty much settled. People from the exchange have repeatedly said from stage 1 and have just recently announced that brokers will be paid on parity to market. And in point of fact, the individual carriers who sell their product through the exchange will actually be paying the commission. In small group commissions, because the small group product will allow a person to sell multiple carriers under one policy, those commissions will be paid by the exchange. When we say parity, by the way, we don't know whether that means exactly the same or not, but common sense tells us that if the exchange commission rate was not comparable or in parity with the open market rates, the broker simply would not get involved, and clearly the exchange wants the brokers involved. Where there could be some differences in what's known as the shop. That's the small group market, and that'll operate very much like a California choice. There'll be standardized plans, but an employer group of, say, 10 employees will be able to buy the shop plan and have 2 of their people perhaps enroll in the Blue Cross network, 2 in the Blue Shield network, 2 in the United network, or whatever it may be. It'll be a multi-choice product design, just as with the CalChoice. Covered California. Covered California is going to be the marketing name. So that's what everybody's going to be seeing up on the billboards and the newspaper and the radio and whatever it may be. Covered California has a series of metal plans that are consistent with requirements of the PPACA, and they have been decided what those metal plans are going to be, and we're going to talk about those in a few minutes. The healthcare providers, who's going to be involved, which carriers are going to be involved as of this recording, has not been decided. A request for proposals have been put in, and it's our understanding that over 200 different provider groups and carriers and health plans have submitted RFPs for different areas around the state. I want to clear up one thing before we go much further with the Covered California. People generally, brokers in particular, have been using the word subsidy and premium tax credits to be interchangeable. And those 2 things are really different concepts inside Covered California. Premium taxes have been around for about the last 8 years. Premium taxes are available to someone at a certain economic level today. If they file their 2012 tax return in spring of 2013, they can apply for premium tax credits back from the federal government. So as an example, let's assume I've paid $12,000 for private market insurance in 2012. If I was a certain economic level, when I file my tax return in the spring of 2013, I could get a premium tax credit for $12,000 or $10,000 or $6,000 or whatever it may be. That money's available to me and has been available to me for the last 8 or 10 years. Covered California simply makes a small change in that premium tax credit. The small change is this. They effectively do an estimated tax return for the individual. And the premium tax credit, instead of waiting to the end of the year to get the money, the premium tax credit is given to the person every month. Instead of shipping the money to the person's home, it is shipped to the exchange in their name. So let's go back to the assumption that I just had, that I was allowed $12,000 of premium tax credits, $1,000 a month. Let's say for fun that my total policy through the exchange was $18,000. That would mean I need $1,500 a month to pay my premium. Covered California would write to the IRS on my behalf, and the IRS would send to Covered California $1,000 every month in my name. I would then write a check for $500 and send it to Covered California. Covered California would in effect tie the $1,000 that they got from the federal government as premium tax credits and my $500, tied it up in a nice little bow, and send it off to whatever carrier I had bought my insurance policy through. Now you can see why the carriers like this particular deal. If I'm buying a policy from Blue Shield really doesn't care whether I pay the $1,500 a month or whether the federal government pays $1,000 and I pay $500. They still get their $1,500. Now some people erroneously describe that premium tax credit as a subsidy, and they mean the word to mean a help, somebody subsidizing the premium. But the problem with that statement is subsidies is something else. Subsidy is a way to help me pay my first dollar claims. We'll get back to that in a moment. But for the time being, I want to make sure we've distinguished premium tax credits are those dollars coming from the federal government to assist me in paying for my health insurance premium. Same premium tax credits I could have got last year, the year before, and the year before that, but the only difference is they're paying it to me in advance. The natural question should be, what happens at the end of 2014 if it turns out I shouldn't have gotten $12,000 in premium tax credits but only $6,000? And the answer is I will owe the federal government $6,000. They can come after me for that $6,000. They can withhold my return. They can do whatever they do in any other situations where somebody owes the federal government tax money, because that's exactly what it is. There's also something called a small group tax credit. Premium tax credits are for individuals. The small group tax credit is for a small business owner who buys his policy through the shop. Again, these tax credits have been available for the last couple of years. It's going to be available for another 2 years under Covered California, but it's really not going to be that much of a game changer. The tax credits are very small. They help a small business offset some of the costs they pay, but in order to maximize the tax credit, say you're going to maximize at 30% of the premium. In order to maximize that tax credit, you have to be a business of 10 people or less with an average income to each of those persons of $25,000 or less. You can get money up to 25 lives and $50,000, but up at that range it costs you more to file it with your CPA than what you collect. So the fact of the matter is only about 12,000 small groups have taken advantage of this in the 2 years that it's been available. And not much of that is going to change because, as you probably know, groups of 10 or less paying as little as $25,000 a year per employee aren't likely to have group health insurance. We talked about the fact that Covered California has to design metal plans. But PACA basically requires every person in America to have a certain level of coverage. That level of coverage is defined as essential benefits, we'll talk about in a moment, plus metal level coverage. As you can see on the screen, you have a bronze reading from right to left. You have a bronze, silver, gold, and platinum level. Bronze is the lowest level. And basically, PACA says, if you don't have at least bronze level health insurance, you effectively don't have health insurance. That's sort of a rule to avoid someone saying that they've given their employees health insurance and put in $1 million deductible. That's effectively like not having health insurance. So while it's health insurance by name with $1 million deductible, it doesn't meet the minimum standards, which is bronze. In our state, Covered California has done some actuarial work, and you can see from the benefits shown on the screen what kind of benefits are listed as bronze. If you look closely at that, I suspect you'll find that most of the small group products you're selling today are already sitting at the silver and gold level. Now, what you're looking at are for individual products at this point, and there will also be product for small group as well. These metal levels will be copied, not the precise benefit being shown, but the percentages of coverage will be copied by every carrier in California. This will be done so that Blue Cross, Blue Shield, United, Kaiser, HealthNet, each of them can say, these are my bronze coverages, and make it easier for the consumer and the broker to compare across different carriers for similar but not identical kinds of plans. If you want more detail, because these slides are pretty small, go to www.coveredca.com and you'll find all the slides that we are about to show you. I'm going to go very quickly through these because we only have a limited amount of time, lots of important topics to discover. But as you can see from this Platinum Coinsurance and Platinum Copay plan, that this is a very rich set of benefits. These benefits design that you're looking at represent about 90% coverage of the average Californian's medical bills. Most of us are not selling policies at that high a level. Silver is shown at the 70 to 80% level. You may note that the Silver Copay plan shows up to 69.8. That's because PACA allows some wiggle room. Each carrier or the exchange is allowed a plus or minus of 2% when identifying its silver coverages or its bronze coverages. By the way, the gold plan covers the 80%, so bronze is 90, gold is 80, silver is 70, and the bronze plan is 60% saves. So platinum 90, gold 80, silver 70, bronze 60 or more. And as you can see, these are very high copayment plans. There is also available a catastrophic plan, which only can be sold to people under the age of 30. While we recognize that most of us in the business see a high out-of-pocket limit like $6,400, or an integrated deductible 6,400 as being something we wanted a wealthier, older individual to have, and they would want it. We sell lots of those. That's just not the way PPACA defines it. So the catastrophic can only be for the sub-30-year-old. Now, we talked earlier about these premium tax credits. The way a premium tax credits works is that PPACA defines the most that a family or an individual can be charged when they buy their policy through the exchange. Rather than telling you how much the tax credit will be, they simply say to the state, since each state's going to have different amounts of premiums charged for an average person, here's the most that you can charge, and whatever more is needed, that is the premium tax credit. So take someone at a 400% federal poverty level, way over in the left-hand column, and he's a family of 4. As you can see from the chart, the most he can be charged is $8,379. Let's assume the policy for that family of 4 was $23,379. The family would have to pay the $83.79, and the federal government would pay the state of California exchange the $15,000 premium tax credits. These premium tax credits, by the way, are calculated on a silver level plan. Now, we talked about the difference between premium tax credits for the individual and benefit subsidies, and here's the chart that demonstrates that. What this chart is simply saying is, let's assume you're a person with $23,000 to $35,000 worth of income. That would be the second column reading from the left. If you had a bronze level plan with a deductible of $60, say, or a preventive primary care visit copay of $60, you would only have to pay the doctor $4 according to that chart for the primary care copay. The other $56 would be paid by the state as a subsidy to assist you with your first dollar coverage. We don't know whether it's going to be a question that the state will pay the doctor, the state will pay the health insurance carrier, and the carrier will pay the doctor. We don't know how that will work, but we assume an ID card will be created for the person who buys this individual policy through the exchange. That ID card would then be coded to say Don Goldman has a bronze level $60 office visit copay, which gets knocked down in his case for $4 because of his low income. As you can see, the subsidies run out at the $94,000 limit. So these are what we call subsidies, and I think you'd be well advised as a broker to make sure your language is correct when you talk to your employer groups and your individuals. Premium tax credits for the individual, benefit subsidies for the individuals are two different things. One is tax credits from the federal government. The other, as you can see here, is the state's assistance in paying for first dollar benefits. What else do we know about the exchange at this point? Well, the number one thing to keep in mind is any small group that is going to get a penalty for not providing, any large group that is going to get a penalty for not providing health insurance. The only way that a penalty accrues is if an employee goes to the exchange and actually gets a premium tax credit. So, for example, I have a 1,000-life group. I don't offer them any coverage whatsoever, and for some strange reason, every one of the 1,000 employees who go to the exchange do not get any premium tax credits. Then as an employer, I'm off the hook. I have absolutely no penalty. When we talk about our third class today, you're going to discover that penalties could occur to all sorts of groups. But whatever occurs, the end game must be that the employee goes to the exchange and gets a premium tax credit. If he doesn't get the premium tax credit, no harm to the employer. The key issue, premium tax credits. The IRS has ruled two ways on something called affordability in connection with the California Health Benefit Exchange, and you need to distinguish between these two things. We have affordability lessons for the employer and affordability lessons in the health exchange. Let's talk about the employer first, and we're going to cover this again in another hour. Affordability of the employer is that he offer a bronze level plan, which we've already talked about, that covers essential benefits, which we will talk about, and that he charges the employee out of payroll deduction no more than 9.5% of last year's W-2 box number 1 wages, and that is for single coverage. So if an employer charges an employee 9.5% or less for single coverage for essential benefits with a bronze level coverage, then the employer has offered affordable coverage. And if the employee doesn't take it, the employer cannot be harmed. Keep in mind, that definition does not translate over to the exchange. When an individual comes in the exchange, affordability is based on a sliding scale, which we'll look at, and it's based upon silver level coverage for the entire family. The employer is for dependent on, it's for the employee only, exchange for the family. Employer 9.5% of the wages, in the exchange on a sliding scale. Employer bronze, the exchange silver. And because we've done enough of these programs in front of a live audience, we know this one question always comes up at this point, so let me address it. Many of you have heard that an employer must offer dependent coverage if he is a large group. But it's been misunderstood. Offering dependent coverage does not mean that the employer has to pay for dependent coverage. Dependent coverage under PPACA means dependent children, not the spouse. And all the employer has to do is has a policy that will allow children to come onto the plan even if the employee pays 100% of the cost of doing that. The affordability issue does not relate to covering dependents. So it's 9.5% on single coverage. The shop also obviously has those same kinds of guidelines for employers coming into the shop to buy their policies. What have we got going? Well, the exchange is working with outsourcing website development, standardized comparative information, very much similar to a Ward & Brown Quote-O-Matic type of quote. The exchange is negotiating with qualified health plans to get them contracted. So come October 1st, you may find the exchange has Blue Cross products, Blue Shield products, United Healthcare products. It may have Health Net. There's no requirement that a carrier participate, and they're negotiating to see who will be in and who will be out. In addition, the exchange will have to be up and ready to inform people, screen people, and enroll people. Remember, since the premium tax credit is based upon how much money a family earns, the exchange is going to have to be able to gather highly confidential information and cross-check it with the IRS. They're also going to cross-check it with the Department of Homeland Security and citizenship eligibility, since you must be a citizen to be eligible for these benefits. They're going to cross-check with the Agriculture Department to see if some people might be eligible for food stamps or healthy families or Medicaid, whatever it may be. So there's a lot of private information, and they're developing systems to gather, protect, and transfer that information to the federal government. When the entire system gets active, obviously the exchange is going to have to reach out and get people into the system. Brokers will be part of that reaching out, marketing, advertising, etc. There'll be multiple points of entrance through a brokerage office on a computer at home perhaps, telephoning in and talking to someone live. The exchange might have an office in a strip mall right next to the farmer's insurance, for all we know. Lots of different points and ways to get in. But everything that happens has to be integrated in the exchange so that a person can, for example, go into Medi-Cal if they qualify for Medi-Cal, but then if they suddenly earn more money, they have to be able to move up to a private purchase policy. Likewise, a private purchase policy through the exchange might lose their job and become eligible for Medi-Cal, food stamps, healthy family, whatever be. And this movement around all these integrated programs has to be seamless. So the task is quite large, and the reports we're getting through the exchange is that they are on track to launch for October 1st. So you don't get confused. October 1st would be the start of selling for January 1st, 2014 effective dates. Well, we talked about those bronze levels, silver level, etc. We're going to talk a little more about that in a few moments. But let's talk about what is essential benefits, because policies basically have to have a certain level of coverage. And for California, this is not a big deal because most of our mandated benefits have already been up to the level of essential. In other states, they might have a problem increasing the kinds of coverages. But in California, we passed a law, as you can see on the screen, SB 951, AB 1453. This was passed in the fall of 2012. And it basically said we are going to use essential benefits which are already described in certain private policies. In particular, we're going to use the Kaiser 30-1500. But keep in mind, this doesn't mean that every plan has to be like Kaiser 30-1500. It means that the plan's language must be compliant with Kaiser's 30-1500. So if Kaiser's 30-1500 were to have a fertility description that included in vitro fertilization, other plans would have to have that type of language. Now, Kaiser doesn't do that, so other plans will not have to do it either. But keep in mind two things. When a benefit is described, such as we cover maternity benefit, does that mean you're going to cover it with a deductible or without a deductible? How many days are going to be involved? So what the language is saying is essential benefits says describe maternity coverage the way Kaiser does, but when it comes to whether you use a $30 copay or $40 or $50 or $1,500 deductible, whatever, those numerical values apply to the metal category. It's the metal category such as bronze covering 60%. Every carrier will have different copays and different deductibles. As long as on average it covers about 60% of the claim, then that would be described as a bronze coverage. So the bill that talks about essential benefits being compliant with the Kaiser policy doesn't demand the same copays and deductibles. In addition, because Kaiser did not meet the definitions of the Federal Health Plan's pediatric vision and the Health and Family's pediatric dental, and yet PPACA says you have to have those, the language for pediatric vision and pediatric dental was taken out of those two plans you see on the screen. Essential benefits and metal benefits describe what insurance is and is not. So someone purchasing a non-essential benefits policy with less than bronze coverage, even though he has a policy that says health insurance, he does not have health insurance as defined by PPACA, and he would be liable for a penalty either for himself or for his large group. In this essential benefits, there are 10 major categories, and you can see them on the screen. We won't review them in depth. 10 major categories that PPACA requires every essential benefits policy to have. However, it defines the subcategory by the state. So that means different states are going to have different essential benefits. In California, our essential benefits is going to have a 2-day minimum hospital stay if the mother wants that for maternity, because that's part of our mandate. Some other state could have no days. They could have outpatient maternity, whatever it may be. So there's going to be different subcategories, and that's going to make all the difference in the world, state to state. Items that we don't currently have completely intact in our plans, rehabilitative services. Rehabilitative services we understand as being corrective work. I injure my shoulder, my workers' comp rehabilitates my shoulder. Habilitative services refers to helping someone with an ongoing and continuing condition that cannot be rehabilitated simply to maintain functionality so they can have a regular life and go to work. Assisted reproductive technology, I mentioned that. Kaiser language doesn't include fertility, but Kaiser language may include some fertility counseling. And if that's the case, then all the small group products would have to have some fertility counseling. Hearing aids, surgically implanted devices are going to be different from carrier to carrier. That'll be standardized. Acupuncture will probably have to be standardized, along with chiropractic will have to be. There'll be some services where we currently have internal limits that would have to be increased in order to meet the definition. We find most of those internal limits around physical, occupational, or speech therapy. Some skilled nursing may be also involved. Whatever essential benefits are defined as, you have to cover basically 60% of them for an average individual and an average claim in order to meet the bronze definition. Now that's kind of a silly thing if you think about it, because there really isn't any such thing as an average claim for an average person. Here's why. If I have, 1 million people in my risk pool, we know that about 92% of them barely have any claims at all, barely get any benefit back, barely ever meet their deductibles. It's because the way health insurance risk pools work, 8% of us get very, very sick and use the majority of claims. So how do we say what an average claim might be? Well, if I was clairvoyant enough, I'd simply take all the people in the United States, look at all the claims that are paid for all of them, even though I know 8% of them chewed up most of the benefits. I would divide it out, and I would have an actuarial value, an average actuarial value. And let's pretend that it was $10,000. Everybody in America had an average benefit claim of $10,000. I didn't have anything, but the guy next to me might have had $1 million. But on average, it's 10. If I then design says, Mr. Insured, you have a $4,000 deductible. I, the insurance company, pay $6,000 of the 10. Then the insurance company is covering 60%, and that is a bronze plan. If I change that design so that it's a $3,000 deductible, insurance carrier pays 7, insured pays 3, that's a 70% or silver plan. Gold is 80, meaning you have a $2,000 deductible. Platinum is 90, meaning you have a $1,000 deductible. Now, if you think about that for a second, it should clear up some of the misunderstanding that all plans are going to be alike, because a bronze plan, remember, as I mentioned earlier, could have a plus or minus of 2%. So a bronze plan could be as low as 58% coverage to as high as 72% coverage in the 60 range, plus or minus 2%. Needless to say, a 12% difference in benefits from 58% to 72 clearly shows you there's going to be lots of benefit difference and lots of pricing differences. So there's still going to be a robust set of options within the market. But in order to understand these metal benefits, you have to think in terms of an actuarial analysis of claims being paid on essential benefits, because that's the definition of insurance, at least bronze, covering essential benefits. And of course, as I said, it could be plus or minus 2%. So if we do these calculations and we recognize that people under 30 can have a catastrophic plan that goes below 60%, we'll find out what the feds are going to allow in the future. How do we go about actually calculating all these things? I had made mention that I was clairvoyant and could just calculate all these things since I somehow knew the knowledge. Well, the fact of the matter is, the government actually did go back and gather millions and millions of insurance records to create an Excel worksheet, an actuarial value. They used data from 2010 collected by the Health Intelligence Company, an LLC. They analyzed 39 million insureds over 767,000 different plans, and all of this was adjusted for the changes in the essential benefits called for with PPACA. All of that data was populated into a calculator, an Excel spreadsheet, and you see an example of it right here. Now, these examples are available on the Ward & Brown website. You can go to the actuarial calculator, and you'll find the Excel spreadsheet downloaded from the federal government. As you can see on this particular chart, what they simply done, they said, how much frequency and what's the average cost of someone given a certain kind of benefit plan. So for example, an unlimited benefit plan at the very bottom of the left-hand column, if you were to go to the emergency room, on average you spent $287. Now of course someone says emergency rooms are much more expensive than that. Yes, but if you look at the frequency, it says the frequency on average was 0.4 or about 14.5%, meaning there were about 8 people, each of them getting $287. Multiply that out, and you're coming up with an average emergency room claim of $1,900 or somewhere around there. And now the averages make sense. Well, the data was collected on a whole host of things: specialist care, inpatient care, primary care, the cost all across the country, as well as the number of times the average person went. This cost and frequency, as you see on the slides I'm showing you, was for imaging, speech therapy, occupational therapy. It was for laboratory, x-rays, all sorts of different kinds of things. As you can, skilled nursing, average inpatient days, mental health, some more different kinds of imaging, speech therapies. You can go to our website and see all these charts, but they classified thousands of pieces of data to come up with this calculator, and all of these things were put into an Excel spreadsheet in order to come up with a way for a person to take a policy and deconstruct the policy into its component pieces. And this is what you're looking at here. It's the Excel spreadsheet that the government gave us that allows you or a carrier to go in and say, here's what my plan's made up of. I'll enter data about my particular plan, and it will use that data in what's known as a macro formulary to go back and collect that data you saw on those earlier sheets. It'll then say, if you have this type of plan with this type of deductible for this type of benefits, what's the average expectation, how many people will likely to have it, and it'll start to roll up those mathematical calculations in order to come up with a final analysis that says this particular design is 65%, 75%, 85%, whatever it may be. In order to give you a better idea, I'm going to take this little screen you see here and take it apart, drill down into it, look at it a bit closer. Here's the whole thing. As you can note right from the beginning, in the upper hand corner, they're actually looking at HSA and HRA as part of the calculation. So while we don't know exactly what will and won't be allowed in HSA and HRA, clearly they anticipate some involvement in those types of products. We're going to look at different sections that are being labeled 1, 2, 3, and 4 now. Let's go to the general plan design, category 1. That was very at the top. In deconstructing your plan or designing a plan from scratch, the calculator would ask the insurance company or the self-insured employer, are you going to integrate your medical and drug deductible? If so, it's going to handle your deductible differently than if not. Are you going to have inpatient co-payments per day? How are you going to handle the maximum out-of-pockets? Are you going to have HSA, HRA option, employer contributions, blended network, unblended network, whatever it may be? And numbers are going to be placed into each of them. As you can see, if you have a two-tiered plan, in-network, out-of-network, you're going to have different kinds of deductible for medical drugs or combined, both in and out-of-networks. Maximum out-of-pockets could be differently. So we'd simply examine a policy, pull it apart, add the numbers in here. We would then input specific benefit values. For example, under the type of benefit, medical, it talks about emergency room services. If I had a $500 deductible, is the emergency room subject to that integrated deductible? If so, I check the box. Is it subject to the same 80-20 or 90-10 or 70-30 on coinsurance? If it's subject to it, I would. But let's say for some reason I decided for emergency rooms that I was going to have separate co-pays and different coinsurances in order to perhaps design a plan that would encourage people to go to the urgent care but not the ER. I would then uncheck the boxes and put the necessary data into the columns marked different or separated. As you can see, Tier 1, Tier 2 talks about two types of networks, in-network or out-of-network, or perhaps a limited network and a broader network. whatever the plan design may be. You have rehabilitative speech therapy, further down, x-rays, skilled nursing. Every one of those benefits would be determined from the policy and placed into the calculator. Section number 3 would be more specific about the drugs, the different kinds of drugs, co-payments, whatever it may be. Again, deconstruct the policy with generic, brand, preferred, and add them in. The fourth category is the output. The calculator, when the calculator button is hit, would simply take the data from the 2010 study that we had shown you earlier and say, how would these benefits compare against the actual habits of people from 2010? And it would calculate some numerical number, 68.2, 78.3, whatever it would be, and classify it as a metal tier. Well, your small employer would not have to do this themselves because the carrier would be doing this work. A self-funded plan or a larger carrier, a larger client may have to do this. A number of our brokers go to our website, download this calculator just for the fun of it, and try their hand at deconstructing a small group product to see how it comes out. As you can see, we can do lots of different examples and calculations on that kind of thing. We've got a few minutes left, so we want to talk about one very important thing. We mentioned the fact, and we're going to repeat it in another course today, that large employers are mandated to provide coverage or they may face a penalty. One of the penalties that no one has yet really started talking about because the testing has not yet come about. We can test for essential benefits, we can test for the metal, as we've just shown you. But highly compensated employee testing or discrimination testing is going to become part of our world in 2014. What does it mean? Well, originally Papaka said we were to test whether highly compensated people were getting better benefits than less compensated people, and we were supposed to start testing that in 2011. However, on December 22nd, 2010, the IRS came back and put a safe harbor on and said nobody has to test. The reason is this is a very complicated set of tests. It's still not come out. We expect it to come out before October 1st, hence our Part 2 discussion we mentioned at the beginning of this course. The reason this is of interest to you, discrimination testing will apply to every group, small or large, regardless of size. The discrimination penalty will be $100 per day per person discriminated against. So while a lot of us have people upset about a $2,000 or $3,000 penalty for not providing health insurance if you're a large group, keep in mind, if you've got a group of 24 and you have a selective carve-out giving the top paid people a very good program and the 20 people underneath nothing or very little, if that's declared to be discriminatory in 2014 or a later date, the penalty could be $100 a day per those 20 people, or not $2,000 a year, $2,000 a day back to the date of the discrimination. We expect the regulations out at any moment, so stay in touch with Ward and Brown. The one thing we are hoping for is this, that whatever set of discrimination rules occur, that they set the discrimination date some time in the future. In other words, if they announce the rules, say September 1st, that they say discrimination testing won't start until the next renewal, or perhaps starting October 1st next year, 2014, or whatever may be the case. That will give us enough time to go back and make the necessary changes so that small groups are not subject to the penalty. Logic and history suggests that the discrimination testing will probably be based on design. What I mean by that is design where we come in and a small employer wants us to give his highest paid people and his family members a very high expensive policy, 100% paid, and give the people in the shop a very low policy. That by design is discrimination. If the logic of testing discrimination by design occurs that way, then we'll be able to make the adjustments with each of our clients without any problem. This may also account for why you've heard a lot of carriers say that they are no longer going to do carve-outs, because if you think about it, carve-out by the nature of things is discriminatory. What we're going to have to work with is how we get around things such as a trucking operation who has one set of benefits for people who work and stay in one location versus their cross-country haulers or the short haul truckers who, by the nature of things, have to have a different set of benefits compared to the people that are in the office. The IRS is wrestling with these questions, and as soon as they release it, we'll get a class back out to you. What we do know is this. Highly compensated testing based upon other IRS regulations already in play are uniformly aimed at the 5 highest paid officers or anyone owning 10% of a company's stock. We use the term stock, we simply mean 10% ownership. So 5 highest paid or people owning 10% of the company, if they're getting a benefit, they're going to be tested. In larger companies, anybody in the top 25% of the highest paid employees, they would also be tested. And what happens if they get tested and fail? Well, the first thing that would happen is, no matter how small or large you are, the company would no longer be able to deduct health insurance as a usual business expense. So they lose their tax deductibility. Secondly, the persons who are benefiting from the discrimination, the 5 highest people, the 25% highest paid, the 10% share owners, they could be taxed individually on the value of the policy that they are receiving. Obviously, the group would be subject to any civil or tax penalty allowed under PPACA, which is the $100 per day, and size doesn't matter. Even a 3-life group will be tested. 2-life group. Obviously, 1-life group can't be tested because you can't discriminate against yourself. Testing hopefully will be designed on design rather than outcome, but we'll talk to you about that as we go along. Secondarily, as of March 1st, the requirement for an employer to notify his employees about the exchange was put into safe harbor. At some point, we'll probably cover it under Part 2, late summer, early fall. We'll be telling you about notices that have to be put up by the employers, notify the employees about the exchange. This will be true for all companies. The notice is going to include information that the exchange exists. It'll describe what an exchange is and how it works. It'll talk about how to contact the exchange for assistance. And we'll have an explanation about those premium tax credits, the actuarial values, the essential benefits, and those subsidies that we talked about in this last hour. Finally, it'll talk about the fact that the employee will not be allowed to take the employer's contribution and take it over to the exchange. If they go to the exchange, they lose the employer's contribution. Obviously, PPACA encourages employers to provide coverage, not shove everybody to the exchange. And so that last bit of information is hopefully designed for the employee to willingly participate and pay his fair share, which, as you remember, is 9.5% of his gross income from last year's W-2 Box 1. Pay his fair share in participating with the employer's policy. The posting was due up by March, but has been postponed to some future date, and we'll get that information out to you when it occurs. We'll also have templates available to you. I'm sure the government will release those. New hire requirements for large groups and for small groups. Waiting periods cannot exceed 90 days. Here in our state, we may end up with different waiting periods for new hires, but PPACA is describing 90 days. Also, auto-enrollment. Every employer group with 200 or more employees will automatically enroll the employee in essential benefit plans, bronze level, whatever that may be, and then the employee will be given the option to buy up or to disenroll himself from the plan. Keep in mind, if an employee buys up, the 9.5% applies to the bronze level plan. That's the affordability test we talked about earlier. Waiting periods may be subject to other limits within each state, so that will vary. And rather, obviously, the employee can opt out, but he has to affirmatively go and opt out. He's covered automatically unless he says no. The implementation date of this is unclear. At this point, we're advising people that it will be a renewal come 2014. What's our conclusions? Well, number one, make sure we're doing our best faith effort on our SBCs. Make sure we're either, if in doubt, handing it out, follow the carriers. Recognize that the exchange will be up and selling come October 1st. Your clients and your individual clients will be seeing information about sometime midsummer, advertising, web information. Keep in mind the essential benefits will have to work into contracts. And although those will not be big changes in California, there will be big changes in other states. And we're going to have to understand the actuarial value of bronze, silver, gold, and platinum. Please do go to the Ward and Brown website and take a look at that Excel spreadsheet. Finally, if you have someone who's clearly and without questioning doing major discrimination in their groups, you may want to start talking to them in 2013, get them prepared. While we can't define exactly what discrimination is yet, hopefully by part 2, late in the summer, we'll be able to do that for you. But I think most intelligent brokers know when there's real serious discrimination going on within a given group, and you may want to start advising your clients to prepare for that change. Those are the major things you're going to want to look out for in preparing for 2014. We're going to give you 2 more courses in this healthcare reform update series, one about small group and one about large group, and hopefully you'll tune in